Atrial fibrillation and flutter are very fast electrical discharge patterns that make atria contract very rapidly, with some of the electrical impulses reaching the ventricles and causing them to contract faster and less efficiently than normal. Two things can occur. One is if the atrial impulse, all of them, they do not reach the ventricle. If they reach at a faster rate, there will be tachycardia, but the impulses are weaker. The left ventricular contraction is less efficient. So atrial fibrillation is a type of supraventricular arrhythmia. Isn't it? Above the ventricle, something is going on in the atria, supraventricular tachyarrhythmia. Most common arrhythmia in clinical practice is atrial fibrillation. 5% of the older population above 70 years, it is very much age-related. Have atrial fibrillation. Prevalence of atrial fibrillation increases dramatically with age. And also, atrial fibrillation is associated with 1.5 to 1.9 times increased risk of death. Disorganized atrial activity, progressive deterioration, atrial electromechanical function, and there are several theories for that. You have mentioned certain things. One, the absence of P waves is the ECG diagnosis. P waves are generated due to atrial contraction. In atrial fibrillation, P waves are absent. Where do I look for P waves? In lead 2, lead 3, AVF, and V1, particularly lead 2 and V1. And rapid oscillations, we will see these are called the fibrillary waves or F waves. Low amplitude wavelets are mostly a flat baseline. You see, vary in amplitude, frequency, and shape. It is an irregular heart rate. What is irregularly irregular? A person comes daily late to the college. It is 9 o'clock, he comes at 11 o'clock. That means regularly irregular. Another person is there who comes one day at 9 o'clock, another day at 6 or 4 o'clock, another day at 11 o'clock, irregularly irregular. Okay. So, narrow QRS only because it is supraventricular, there are re-entry pathways. So, you can see here, there has RR interval, shorter, again longer, like that. Atrial activity is, fibrillary waves, you can see 350 or more, and then irregular fibrillary waves, and then PR interval you cannot measure correctly, but the QRS is very normal or less than 0.12 seconds. Anything occurring in the ventricles, the QRS will be widened. So flutter, you see, flutter waves are, capital FV, right? And there will be a regular pattern, 2:1 or 3:1 like that. Whereas in fibrillation, there is no such relation. Sometimes atrial fibrillation can be triggered by a premature contraction. So it's a premature contraction and that triggers the atrial fibrillation. Okay. There is what is called WPW syndrome, which is a Kent pathway bypassing the AV node. The PR interval shortening will be there, delta waves will be present, and they fuse with the QRS, and then looks as though the QRS is very wide. STT is secondary to the ventricular activation. Why should I know? This is another form of conduction abnormality, just like this can also be there along with the atrial fibrillation. So this is the Kent pathway, this is the normal pathway is to the AV node. There is another pathway through the Kent pathway. It comes and excites early, and depolarization goes like this. There is what is called shortening of the PR interval. There is a delta wave. P wave is normal. Delta wave is seen because of the apparent conduction, and there will be an inversion of the T wave. And this apparent conduction and normal conduction fuse together to form a fused QRS complex. That is a double activation. One activation via the normal path, another activation before the normal activation, the accessory activation, which lead to this bizarre fusion QRS complex. And risk of ventricular fibrillation. You should not ignore WPW because WPW can lead to ventricular fibrillation and a sudden cardiac arrest. Okay, that is beside the point. Now, atrial fibrillation, what is the pathology? Initiating event and permissive atrial structures. Multiple mechanisms may be present. Focal pulmonary vein triggers. They also said that enlarged RA and LA, multiple wavelets, mother waves, daughter wavelets, fixing or moving rotors, micro-rear circuits, automatic force in the atria, excess catecholamine, hemodynamic stress, atrial ischemia, atrial inflammation, metabolic stress may be there. Okay. What is the, why I should study this condition? It's very common and it is a morbid and mortal disease. Risk of thromboembolism is there, associated risk factors may be there, normal atrial contraction is lost, so there is stasis of blood, development of thrombus in the atrial appendage, which can get dislodged to produce embolic complications, non-rheumatic atrial fibrillation, non-valvular cases, stroke rate is quite high. In rheumatic, stroke rates are 5-fold more than in the non-rheumatic. Mortality is doubled with the underlying structural heart disease. There are two types of patients: people who have atrial fibrillation with normal heart, people who have underlying heart disease with atrial fibrillation. With those with underlying structural heart disease, they fare worse compared to those without the heart disease. Atrial fibrillation with a wide array of symptoms. What are the symptomatology? Majority are asymptomatic. If the heart rate is more, patient may experience palpitation, dyspnea, fatigue, dizziness, angina maybe. Okay? Decompensation may lead to heart failure. There could be increase in the B-natriuretic peptide secreted by the dilated atria, and that can lead to natriuresis, which means polyuria. In addition, AS can be associated with hemodynamic dysfunction and congestive heart failure, tachycardia-induced cardiac remodeling, it is called cardiomyopathy. Tachycardia-induced cardiac remodeling and systemic thromboembolism. So what you have to do is then remember, there could be hemodynamic dysfunction, there could be cardiac failure, there could be tachycardia-induced cardiac remodeling, or there could be clot which gets dislodged into the systemic circuit. So symptoms are not much except palpitation, some sort of fatigue, dizziness, angina, dyspnea, failure, symptoms of heart failure. Clinical signs. What are the clinical signs? Patient feels irregular heartbeat. Pulse apex disparity. This is called pulse deficit. Okay. So not all the contractions reach the periphery, and the cardiac contractions, some of them are weak. They don't generate a pulse wave. Pulse deficit can be there. Two people have to record. One auscultates, one palpates the pulse. Start, both will start. End, exactly 1 minute. May or may not have tachycardia, depends on the AV node. If the AV node is permitting more of these extra impulses to go, there will be tachycardia. When the AV node is defensive, then you will not have the tachycardia. So, what will be the first sound? Variable intensity. Why? First sound is dependent upon the AV valve closure. AV valve closure is again dependent upon the proper atrial activity. Occasionally, S3 may be there, but S4 is absent in all cases. Absence of A wave in the jugular venous pulse, signs of underlying heart disease, like rheumatic heart disease, and GAD, obstructive cardiomyopathy, dilated cardiomyopathy. Look for heart failure and atrial embolization. Have WPW associated, ventricular rate will be more than 200. Why I told about WPW? Because some of the patients of atrial fibrillation do have an aberrant channel which promotes the impulse to travel faster, and ventricular tachycardia is manifest. Normally, QRS tachycardia, the narrow QRS tachycardia, and may be wide only in some cases. So what are the clinical signs? Irregular heartbeat, pulse deficit, tachycardia depending upon the AV nodal conduction, variable intensity for start sound. Occasionally, S3 may be heard, S4 will never be heard, A waves absent in the jugular venous pulse because there is no active contraction of the atria, underlying heart diseases, rheumatic, coronary, HCM, dilated cardiomyopathy. May be evidence of atrial fibrillation, atrial embolization, or cardiac failure. We have associated WPW, and usually the tachycardia is narrow QRS. What is the effect of age on atrial fibrillation? Less than 60 years, only 1% of the patients are less than 60 years. If you come to around 60 to 79 years, it is 4%. The moment you are more than 80 years, the chances of atrial fibrillation is as high as 8%. Very high rates of atrial fibrillation are seen in people who are very elderly. So what are the causes? Rheumatic valvular heart disease or VHD, diabetes, hypertension, CAD, LV dysfunction, common soil hypothesis, endothelial dysfunction leading on to the atrial fibrillation. Male gender, advancing age, hyperthyroidism is another condition which can produce atrial fibrillation. Congenital or structural heart disease, left atrial and right atrial diseases may be there. Cardiomyopathy, excess of alcohol or illicit drugs, acute pulmonary problems, and cardiac surgery. Commonest, rheumatic. Second one is endothelial dysfunction associated diabetes, hypertension, CAD, LV dysfunction, male gender, advancing age, hyperthyroidism, congenital or structural heart disease, cardiomyopathy, alcohol, illicit drugs, and also you have finally the acute pulmonary problems and cardiac surgery are the causes of atrial fibrillation. Definitely, this will be asked in the examination. If you have a case with atrial fibrillation, they will grill you. What are the reasons for atrial fibrillation? Electrical reasons, the pathophysiology, the atrial fibrillation, the causes of atrial fibrillation, and then the treatment of atrial fibrillation, every aspect. This is one condition you cannot ignore to learn perfectly. Hemodynamic stress, intra-arterial atrial pressure is increased, mitral and tricuspid valve disease may be there, LV dysfunction, systemic pulmonary hypertension, atrial ischemia, CAD, ventricular ischemia, and lead to increase in the left atrial pressure. Sick sinus syndrome, inflammation, drug use, alcohol. Endocrine, commonest, hyperthyroidism. Neurologic, subarachnoid hemorrhage and stroke can trigger atrial fibrillation. Familial atrial fibrillation is one condition called familial atrial fibrillation. Cardiac surgery and collagen diseases. Sometimes we may not identify any cause. Underlying structural heart disease, if present, it indicates bad prognosis. Atrial fibrillation with structural heart disease, usually bad prognosis. What are the structural heart diseases? Rheumatic valvular, hypertensive heart disease, cardiomyopathy, congenital heart diseases, coronary heart disease. Elevated BNP, B-natriuretic peptide, because there is underlying heart disease. So how do I separate whether there is underlying heart disease or not? Do a conventional echocardiogram and also look at the BNP. Echocardiogram will show underlying disease and BNP will be elevated with underlying heart disease. Atrial fibrillation without concomitant structural heart disease is relatively benign compared to with underlying heart disease. There is one condition called lone atrial fibrillation. It presents in the younger patients without structure. That means they have only lone atrial fibrillation, no other manifestation, no embolism, no heart failure, no structural heart disease. Hemodynamic instability is seen in people with underlying structural heart disease, severe dyspnea, reduced saturation, the SpO2 measure it will be low, follow blood pressure, chest pain will be there. Patient may end up in follow blood pressure and shock. Okay, so that is what is called hemodynamically unstable atrial fibrillation. The first thing you have to decipher is there an underlying structural heart disease? What is the age of the patient? Male gender, advancing age, underlying structural heart disease, poor prognosis. Younger patient, no structural heart disease, better prognosis. Second thing is the patient hemodynamically stable or hemodynamically compromised? If it is hemodynamically stable, Our treatment approach is different. If he is compromised, then our immediate treatment will be electroconversion. Okay, 12 lead ECG should be obtained immediately. Look for pre-excitation WPW. Determine the heart rate by looking at 1 minute. You take a strip and count all the sort of QRS and then say this is the heart rate. Because you cannot, from a small strip, you cannot identify the heart rate. The RR intervals are varying. Evaluate basically with the echo for LVH, LVB, previous MI. QT interval and QRS intervals are important for patients on antiarrhythmic drugs. So certain antiarrhythmic drugs, they act by prolonging the QT interval. The patient already has a prolonged QR interval. You cannot use those drugs. 6-minute walk test or exercise test to look at the rate control. Holter monitoring, electrophysiology in selected cases. Transthoracic echocardiography, transesophageal echocardiography. Transthoracic is directly from the chest. Transesophageal, pass an endoscope. Tip of the endoscope, there is a sort of the ultrasound is there, and that gives the measures the echo. That is essential because atria, the posterior chambers, particularly left atrium, I get a very better view, very good view of the atria from the TEE, transesophageal echocardiography. X-ray chest to evaluate for pulmonary disease, thyroid function, renal function, serum electrolytes must be obtained. Remember, these are the investigations. 12-lead ECG, 6 minutes walk test, Holter, electrophysiology, TTE, TEE, chest X-ray, thyroid, renal, electrolyte. Why renal? Because my treatment depends upon the renal function. If the renal function is compromised, I have to reduce my drugs. So I have to be under knowing the renal function. Differential diagnosis, atrial flutter, atrial tachycardia, atrioventricular non-reentrant tachycardia, nodal reentry tachycardia, atrioventricular nodal reentry tachycardia, AVNRT, PVST, paroxysmal supraventricular tachycardia, WPW, digoxin toxicity, cardiac ischemia secondary to rapid ventricular rate, hyperthyroidism, and pulmonary disease, particularly COPD, can lead to right atrial enlargement, and pulmonary hypertension can lead to atrial fibrillation. So how do I do? Go about the algorithmic way, diagnose atrial fibrillation. How? ECG, pulse deficit, and then presence of underlying structural heart disease, hemodynamic stability, and look at the electrolytes, look at the hemodynamic stability, underlying structural heart disease, and endocrinology evaluated, diagnosis is made. Now the question is it chronic atrial fibrillation or new onset? How do I know? If the patient says, yes, I am having from a long time, or if you have got previous ECGs which show atrial fibrillation, then it is a chronic atrial fibrillation. And the treatment is different. New onset atrial fibrillation. And no, sir, whenever I was having now only this palpitation, now only the weakness, previous ECGs are normal, and then is it paroxysmal or persistent? Paroxysmal comes and goes. Persistent, there is no normal interval. Paroxysmal, up to 7 days. He comes and goes, lasts for few days, again normal rhythm, again he gets the atrial fibrillation, which is called paroxysmal atrial fibrillation. The prognosis is much better for paroxysmal atrial fibrillation. Persistent atrial fibrillation, there are no normal intervals. There is permanent atrial fibrillation with cardiovascular failure. So, paroxysmal, persistent, permanent, or chronic. 4 types are there. Now, paroxysmal AF, it terminates spontaneously in less than 7 days, often less than a day. Persistent, when terminates either spontaneously after 7 days or following cardioversion. Permanent atrial fibrillation persists for more than 1 year, either because of cardioversion has failed or because cardioversion has not been attempted. Now, paroxysmal, new onset, paroxysmal, persistent. Paroxysmal is one route, persistent is one route. Paroxysmal end up in permanent, persistent may end up in permanent, or new onset may directly go into permanent. First episode of atrial fibrillation, it is primary or secondary. Secondary to thyroid disease, structural heart disease, coronary artery disease, subarachnoid hemorrhage, or some secondary cause. Structural heart disease and age are the most important factors. AF without structural heart disease is called lone atrial fibrillation, usually in the young. Mitral valve disease, aortic valve disease, hypertension, coronary artery disease, left ventricular disease, dilated cardiomyopathy, hypertrophic obstructive cardiomyopathy, pulmonary embolism, atrial septal defect, hyperthyroidism. Hyperthyroid, not fun, function, means function. Increased thyroid function. Okay? Coffee, tobacco, ethanol, stress, fatigue, these are the triggers of atrial fibrillation. No organic heart disease, no WPW, address the precipitating factor. Observe for recurrence of atrial fibrillation. If the HD is underlying, heart disease is underlying, then you have to do anticoagulation, rate control, rhythm control. Treatment involves three things. 1, anticoagulate. 2, control the rate. 3, control the rhythm. Among all the three, the first priority is anticoagulation, because that is the major risk of thrombosis. Second important priority is control the rate. Rhythm control and bringing it to normal rhythm is the third priority. Oh, it is atrial fibrillation, I want to convert to sinus rhythm. That is not the first priority. What is the first priority? I have to give him anticoagulation protection, reduce the ventricular rate so that the hemodynamic decompensation is corrected, and rhythm control takes the third priority. Paroxysmal atrial fibrillation, no underlying heart disease, rest, sedation, digitalis for the attack. Hemodynamic compromise occurs, immediate cardioversion, DCC. Okay, DC shock induced cardioversion. Hemodynamic compromise is there, means no questions asked. Immediately you have to do. Anticoagulation also will be started, but DCCV is important. Hemodynamically stable, rate control is important. Anticoagulants are added, rhythm control will be next. So hemodynamic compromise, first thing is you control the rhythm, cardioversion. Okay. No hemodynamic compromise, control the rate, give anticoagulant, rhythm control. How do I treat? Beta blockers, calcium channel blockers of non-dihydrofuranidine type, flecainide, propafenone may be used immediately. No structural heart disease. Flecainide. Flecainide is, we know, 1C type of anti-arrhythmic drug. Propafenone also is like amiodarone, class 3 drug. Particularly patient has got structural heart disease or heart failure or dilated cardiomyopathy. Choice will be amiodarone. Sotalol in CAD and hypertension, when there is no, sotalol is a type of beta blocker. Catheter ablation and maze procedures in refractory cases. Okay, this is about paroxysmal. Chronic atrial fibrillation, ventricular rate control is important, anticoagulation is important. We are not worried about the rhythm because it's already chronic and is from long time. I just control the rate so that the ventricles are not fatigued and no CHF. I can give the anticoagulation so much so there is no dislodging of the thrombus. Cardioversion needed only for a hemodynamic benefit. The ejection fraction is lower, then you do a cardioversion, then it improves. Either pharmacological or DC conversion can be tried. Usually no more than one attempt of DC conversion. Reverting to sinus rhythm did not give the extra benefit. FM trial has clearly proved rhythm control takes a back seat. It is most important, hemodynamically unstable, you do DC. And then control bring back to normal. Hemodynamically, somebody is stable, my rhythm control goes back seat. Only anticoagulate control and anticoagulation will be my priority. Long-term anticoagulation. This is one condition where you have to use long-term anticoagulation. How do I start? Poor man, start with heparin, start with warfarin. After 4-5 days, withdraw the heparin. 5,000 units subcutaneously, ordinary heparin or low molecular heparin. 0.2 to 0.4 international, ml will be the unit. Then you give. Like that, you start the anticoagulation and also start warfarin. Take precautions about warfarin use and also the foods, certain foods to be avoided, particularly leafy vegetables and all. They contain a lot of vitamin K, which interferes with the warfarin action, which will blunt the warfarin action. So certain foods, spinach, cabbage, leafy vegetables should be avoided when you give warfarin, and you have to measure the PT-INR regularly so that you won't overshoot the anticoagulation. Heparin reversal by protamine, warfarin reversal by vitamin K. Then catheter ablation to the His bundle with a pacemaker implant can be tried only if refractory, as it makes the patient pacemaker dependent. So a pacemaker and catheter ablation are for refractory cases. Okay. Now, objectives of treatment: relieve the symptoms, prevent recurrence, prevent heart failure, prevention of systemic thromboembolism. That's why I have put it. That is the most important objective of treatment. Okay. Tachycardia-induced myocardial remodeling can occur, which can lead to a sort of chronic cardiac invalidity and heart failure. That also we have to prevent. That is why rate control and anticoagulants are very important than rhythm control. Okay. Management strategies: rate control, rhythm control, warfarin INR should be kept between 2 and 3 in elderly patients, preferably around 2, and then cardioversion in people who have refractory. Rate control, rhythm control, anticoagulation, cardioversion. Okay. New onset atrial fibrillation, not a chronic atrial fibrillation, not a paroxysmal one. New onset atrial fibrillation. First thing is the patient hemodynamically stable or unstable? If he is stable, if he is unstable, if he is stable, then first treatment is anticoagulation and not cardioversion, because I wanted to see thromboembolism is minimized, risk of clot formation minimized, then do a treatment for the cardioversion. Not anticoagulated INR less than 2 for 3 weeks. Anticoagulated INR should be 2 to 3 for more than 3 weeks. Hemodynamically unstable, of course, DCCV is the treatment of choice, because it's a life-threatening condition. You have to revert to the normal rhythm and reduce the heart failure and restore the hemodynamic stability. Anticoagulated INR 2 to 3 for more than 3 weeks. Okay, already anticoagulated. He had 4 weeks of anticoagulation given. INR is well above 2 to 3, normal being 1. And then cardioversion, rate control, outpatient follow-up you can do. Now, not anticoagulated earlier or INR is less than 2 to 3, give warfarin and also control the rate. Or if you cannot wait, then you do a transesophageal echocardiography and ensure that there is no clot in the left atrium. Then do a cardioversion. Recurrent atrial fibrillation. We looked at paroxysmal atrial fibrillation. We looked at chronic atrial fibrillation. We looked at new onset atrial fibrillation. Now we are looking at recurrent atrial fibrillation. Minimal symptoms, disabling symptoms. Minimal symptoms, warfarin, rate control. How do I control the rate? Beta blockers are the best drug. Or use verapamil or diltiazem, calcium channel blockers, non-dihydropyrimidine type. No prevention, no AAD treatment. You don't have to use amiodarone and all those things. No preventive treatment. Minimal symptoms are there. Recurrent, use anticoagulation and control the rate, good enough. If the disabling symptoms are there, then you give warfarin, rate control, antiarrhythmic drugs should also be given, and prevention treatment also should be instituted. Rate versus rhythm, which is important. Integration of several factors, which decides rate is important or rhythm is important. Age of the patient, degree of symptoms, likelihood of cardioversion success, and the status of the anticoagulation of the patient already, and the presence of atrial thrombus, and presence of comorbidity. A very elderly patient, let us say, very symptomatic, likelihood of cardioversion is good, and then the patient is already anticoagulated. I can go for cardioversion. Suppose the other way around, patient is young, there is no chance, no clot there, or he is not anticoagulated, then probably I will do the anticoagulation first and then go for rhythm control. Rate control versus rhythm control is always a question, and a lot of studies have been done to answer this. And the current view is, it is very acute and disabling, and then hemodynamically compromised, control the rhythm. Otherwise, in all other cases, make sure you give the anticoagulation and control the rate. Rhythm control takes a back seat. Okay, what is important? Rate, rhythm, or AC? AC is anticoagulation. Rate, rhythm, or AC? FM trial, race trial, and so many trials are there. Age of the patient, rhythm, comorbidity, older patient, rate, anticoagulation is a must. INR should be around 2 or more. What anticoagulation? Atrial fibrillation is a powerful risk factor for stroke, TIA, and most important treatment of atrial fibrillation is anticoagulation. We forget to give that atrial fibrillation. We want to give them drug to control the rate or rhythm. Anticoagulation is the most important. Acute cardioversion is risky without anticoagulation because the available clot will be dislodged. I have to do a TEE, demonstrate that there is no clot, then only I can do a DCCB. Risk is same for electrical or pharmacological. TE risk increases if atrial fibrillation is more than 48 hours. That means there is time enough for the stasis to occur, and there is thrombus formation, thromboembolic complications can occur. Effective anticoagulation reduces the risk by threefold. Initiation of anticoagulation can be done with heparin or low molecular weight, add warfarin, remove LMW or erythropoietin. Those patients can afford. You can use oral direct thrombin inhibitors like gemilagatran or dabigatran. No INR is required. If you are going to do the sort of direct thrombin inhibitor, no need to do any INR or anything because it is low down in the coagulation cascade. Gemilagatran, which is also available as dabigatran is also available. Risk for stroke in atrial fibrillation. Who are the people who are going to get a stroke in atrial fibrillation? Male gender, advancing age, underlying rheumatic valvular disease, and then diabetes, hypertension, CAD, LV dysfunction. Heart failure, prior history of TIA and stroke are other important factors for risk factors for stroke in a case of atrial fibrillation. Always, the patients will ask, and clinician also should prognosticate whether this patient will go in for a thromboembolic complication and stroke. And these are the points on which you base it. Male gender, advancing age, structural heart disease, coronary artery disease, diabetes, hypertension, LV dysfunction, heart failure, prior history of stroke and TIA. Now here comes the CHAD S2 scoring. 1 point for cardiac failure. Patient has got cardiac failure, 1 point. Hypertension, 1 point. Age more than 75, 1 point. Diabetes, 1 point. 2 points, stroke or TIA or ST. Okay, add this point, and then this is how it is scored. So this is called CHAD S2. Okay, CHAD S2 score point. Adjusted score is stroke incidence, 0.1.9%. The patient has all the 6 points, then there is an 18% chance of stroke. No valvular atrial fibrillation, non-valvular atrial fibrillation with anticoagulation. Okay, now the CHAD score gives you a prognostic indication how much there is the risk of stroke and thromboembolism. Okay. Now, here the thromboembolism is not venous thromboembolism. It is arterial thromboembolism. So directly it can go to the brain or any other peripheral circuits, into the eye, into the kidney, to the peripheral blood vessels of the limbs, anywhere it can happen. How do I risk stratify my patient? high risk factors, moderate risk factors, and then other risk factors. Depending on the risk factors, you can stratify. Risk factors to be ascertained. What are the things I see? Prior stroke, TIA, systemic thromboembolic event, age more than 75, heart failure, hypertension, decreasing AF, diabetes, female, gender, and then CAD, hyperthyroid, age less than. These are other risk factors. Non-valvular atrial fibrillation with anticoagulation. Risk stratification. It's very important. What is the treatment recommended? Less than 65, no risk factors. Aspirin 325 milligrams only. See, what is the treatment recommendation for atrial fibrillation treatment? Atrial fibrillation treatment is anticoagulation you already given. On top of that, less than 65, no risk factors, 325 milligrams of aspirin. 60 to 75, diabetes mellitus, CAD, one risk factor, give aspirin. Two risk factors, warfarin you give. Okay, more than 75, hypertension, LVD, mitral valve disease, and then the previous heart surgeries, and then the stroke, TIA, PE, pulmonary embolism, or more than 2 moderate risk factors. Warfarin must be given or any other anticoagulation. If you give warfarin, the INR should be kept between 2.5 to 3.5. Okay. Somebody has got no risk factors, no structural disease, only a low atrial fibrillation, age less than 65, that to paroxysmal, just aspirin alone is sufficient. Risk of thromboembolism, 1.5% is less than 60, 23.5% is more than 80. Look at that, age has got such an important bearing. First thing is the intern phones me up and says, sir, there is a case of atrial. What is the age? I will ask. The age is more than 80. Is there underlying heart disease? Is he a patient of coronary artery disease? Is he having recurrent atrial fibrillation? Is it new onset? How is his hemodynamic stability? These are the questions I ask over the phone to decide the treatment. How do I prevent? AF is associated with the risk of PE, that is increased thromboembolism, stroke, TIA, peripheral embolism, anticoagulation, heparin and warfarin to reduce the TE, anticoagulation, risk of fatal bleeding may be there, monitor the INR. Antiplatelet treatment with aspirin, clopidogrel also can be combined. Use the CHAD-S2 score to stratify the patient. CHAD-S2 score of 0, need only aspirin or clopidogrel. Because there is no underlying heart disease, there is age is less than 65, it is not a continuous, it is not a life-threatening thing, there is no hemodynamic instability. Naturally, you can just give aspirin or clopidogrel. Is good enough. If S2 score is 3 or more, it requires anticoagulation. Score of 1 and 2, see history of stroke, TIA, CAD, HT, and female gender. So what anticoagulation I use? Heparin, low molecular weight, warfarin. This is a direct coumarin antagonist. Coumalone, phenandione, this is dabigatran, zimalgatran. So trade names are available. This is a direct thrombin inhibitor. This is phenandione, is Dindivan. This is acitrom, is available as acitrom for us in our country. Warfarin is available as VAR for the univarfin, and then fluxam or any other brand of lomarotherapin, and then conventional heparin. Conventional heparin 5,000 international units, subcutaneous or IV, both are same. There is no advantage of giving IV. You have to, what you have to measure? Monitoring is by the APTT. If you do LMWH, no monitoring is required, usually subcutaneous. Once a dose, 0.3 or 0.5 given. Some are having 0.2 and 0.4, some have 0.3 and 0.5. Warfarin, 10 to 15 milligrams, available as 5 milligram tablet. Orally, once a day, INR you have to look for. Here you should not do APTT. Here you have to measure PT-INR. If you use acitrom, 8 milligrams, and also 2 to 4 milligrams tablets are there. You can titrate 8 plus 2 or 4 plus 2. Like that, you can titrate the dose daily, orally, or sometimes alternately. Again, the monitoring is by the INR. Phenandione derivative, Dindivan you use 200 milligrams or 100 milligrams. Orally daily, you use INR is the monitor. If he is direct thrombin inhibitor, like dabigatran or gimilgatran, already when the presentation was made, it was under trial. Now these are available. Only problem is you have to look at the liver toxicity, either rivaroxaban or apixaban or gimilgatran or dabigatran. They don't require any monitoring. You also know now what are the drugs used to reverse those things. How to assess bleeding risk. History of bleeding, 2 points, hepatic renal disease, 1 point, alcohol, 1 point, malignancy, 1 point, older age more than 75, 1 point, aspirin therapy, already on aspirin, 1 point, reduced platelet count, 1 point, hypertension, 1 point, anemia, 1 point, genetic predisposition, excessive fall risk, and then patient of stroke. So each one you start giving this point, and then you know the bleeding risk of a patient. Depending on that, you have to tailor 0 points, that is 1.9%, 4 points, 10.4%, 5 or more points, 12.3%. Bleeding risk outweighs the benefit, no anticoagulation. Suppose somebody is here, then you don't venture to give the anticoagulation. Pregnancy, you can, in the first trimester, you cannot give anticoagulation. When there is an elective surgery planned, you cannot give anticoagulation because intraoperative, perioperative, bleed will be a problem. Rate control of ventricular rate is critical component. Rate controlling by increasing the evidence of refractoriness. Beta blockers to use, calcium channel blockers for the first line rate control, non-dihydropyrimidine, CCBs, verapamil, and then diltiazem. Given either IV or orally, depending upon the need. ROAD patients, beta blockers are withheld, and we use calcium channel blockers. If heart rate is less than 88 reps, you target that. What is the target heart rate? Keep it less than 80, less than 110 with exertion, or 6-minute walk, or on TMT. Digoxin is not used today. It fell out of favor unless the patient is having heart failure. Somewhat useful in patient heart failure and LV dysfunction. Amiodarone, class 2A recommendation for rate control. Class 2A recommendation means the benefit is seen in some studies compared to the other studies, not in all the studies. Class 1 recommendation, number 1 recommendation. Class 3, benefit and risk are equivocal. Class 4 evidence, you should not give. Class 5, it is dangerous to give. That is the classification. Now, main drugs for rate control, we know here we have beta blockers, calcium channel blockers, diltiazem, verapamil, digoxin. All these act on rate control. First preference, beta blocker. In case of pulmonary disease, second preference. In case of heart failure, digoxin is the preference. Rapid rate control with IV drugs, calcium channel blockers, beta blockers, esmolol, metoprolol. Diltiazem is preferred of least side effects. Patients with increased sympathetic tone, esmolol is preferred because it reduces the sympathetic tone. If with heart failure, digoxin is the choice, not a CCB, not a BB, because these increase the heart failure. Digoxin has delayed onset of action, so it is not immediately available for its effect. So you start digoxin, it will take 3 days for the effect to come. Amiodarone is the choice in atrial fibrillation with CHF, and BP is falling. You can't wait for the time, so give amiodarone and not digoxin. Flecainide or amiodarone or AF may have in pre-excitation syndromes, you use them. CCB and digoxin are contraindicated when there is a pre-excitation. Rhythm control. Rate and rhythm control yield similar results. Young patients who remain asymptomatic after rate control in home rate control drugs are contraindicated. Who do not tolerate rate control drugs, rate and rhythm control drug combination can be used. Class 1C, flecainide or the propafenone are contraindicated in coronary artery disease. That's what you have also told. In CAD and diastolic heart failure, amiodarone is the drug of choice. So rhythm control, sinus rhythm requires treatment of severe risk factors and control the hyperthyroidism. Antiarrhythmic drugs restore sinus rhythm. Amiodarone is the safest drug. Its adverse effects may be a problem in some, Sotalol is efficacious for maintenance, requires monitoring of the QT interval and electrolytes more frequently, contraindicated in patients with structural heart disease. Catheter ablation is an alternative to drug therapy in symptomatic patients with structural heart disease. So these are the various drugs like AADs in AF, amiodarone, class 3 drugs, profetilide, class 3 drugs, sotalol, class 3, flecainide is 1C, propafenone, 1C, dronedarone has got all the actions, and beta blockers are class 2 drugs. Okay, so what is the dosage, what is the indication, how much you give, what are the contraindications or special precautions based on FM, CAST, CTAF, safety, and then race trial. This is the table. Okay, so how do I go about algorithm? Maintenance of sinus rhythm, no significant heart disease. You use flecainide or propafenone or sotalol. Not responsive, amiodarone, defetilide, catheter ablation is an option. Suppose you have got hypertension, is there LVH or no LVH? No LVH, same drug. There is LVH, amiodarone, because it can lead to heart failure. And is not responsive, amiodarone, defetilide. And then same channel, like this. Okay, coronary artery disease is there. Now, defetilide and sotalol come as the first, amiodarone as the second. We don't use flecainide and propafenone in those patients with coronary artery disease. Already that has been made out. And catheter ablation in refractory case. Suppose patient has heart failure, amiodarone should be tried. Digoxin takes time, and then catheter ablation can occur. This is the flow chart for maintenance of sinus rhythm. This is not about anticoagulation, not about the rhythm rate control, more about maintaining the sinus rhythm. Cardioversion, electric cardioversion and emergency cardioversion. Elective, emergency. Electrical, chemical. Ibutilide is a chemical drug which is used to cardio work. Most successful when initiated within 7 days. Acute cardioversion and hemodynamically stable patients, pharmacological cardioversion, no sedation or anesthesia required. But risk of ventricular tachycardia, serious arrhythmias can occur. Direct DCCV, direct current energy cardioverter is used, maintain serum potassium in the upper normal range. Otherwise, cardiac asystole can result. Cardioversion, hemodynamically unstable atrial fibrillation, severe dyspnea. What are the indications? Hemodynamically unstable dyspnea and chest pain, pre-excitation syndromes, non-responders with control of conventional therapy, of rate control, without valvular function abnormality, DC conversion, electrical current that is synchronized to the QRS complexes, monophasic or biphasic. The required energy is 100 to 200 joules you have to use. Success of cardioversion in short duration of atrial fibrillation, very good. Left atrium is not significantly large, it is good. Success rate of cardioversion exceeds 75%. Patient is sedated and anesthetized during the cardioversion. Embolization is the most important risk. So do a TEE, rule out that there is no thrombus, then only go for the cardioversion. Or give warfarin for 4 weeks, anticoagulate him, then do the cardioversion. Patient must receive warfarin for at least 4 weeks after the cardioversion also. Thromboembolism, what are the complications of cardioversion? Thromboembolism, pulmonary edema, hypotension, myocardial infarction, skin may get burned, aesthetic changes, elevated cardiac markers because you have given an electrical shock. There could be CPK, LDH, trope, this may be elevated. Synchronization of DC shock with QRS prevents serious ventricular arrhythmia. Pharmacological cardioversion, electrical cardioversion, most commonly used. Pharmacological cardioversion, direct current cardioversion phase, then you can try pre-treatment with amiodarone, flecainide, or ibutilide. So ibutilide is the pharmacological agent used. Propafenone, sotalol increases the success of DC cardioversion. This is not a choice in hemodynamically unstable patients. Then only DCCV is the choice. Who should be admitted? I have a patient of atrial fibrillation. Should I admit him or not? How do I know? Hemodynamically unstable patient, new onset atrial fibrillation, underlying heart disease, underlying heart failure, older patients, more than 65, associated coronary artery syndrome, and comorbid problem. Somebody is young, no structural heart disease, and it is a chronic atrial fibrillation, hemodynamically stable. I don't admit him and treat him accordingly. Long-term management, reduce the chance of recurrence, and now atrial fibrillation related symptoms, control the ventricular rate and risk of thromboembolism, and the stroke you have to reduce, manage the CV risk factors, anticoagulation is the must for all except low atrial fibrillation, younger patients, rhythm control, older patients, rate control. Atrial fibrillation begets atrial fibrillation. Sinus rhythm begets the sinus rhythm. If you induce sinus rhythm, it continues. If it is atrial fibrillation, it can produce recurrent atrial fibrillation. That is the surgical treatments. What are the surgical options? Atria are transected and resutured to reduce the critical mass of the atria. Maze procedure is an attractive procedure. Catheter ablation is widely used. Compartmentalization with continuous ablation line. Catheter ablation of Fokker triggers, AV node ablation, insertion of permanent pacemaker, percutaneous closure of the atrial appendage to reduce the thromboembolic risk. Post-ablation, antiarrhythmic drug therapy is essential. So what are the take-home points in atrial fibrillation? Atrial fibrillation is the most common arrhythmia. Evaluate for any underlying structural heart disease. Classification of patients. Risk stratification using the chart score. Look at the age of the patient, underlying heart disease, hemodynamic instability, coronary artery disease, heart failure, thyroid. And is he already an anticoagulant? Thromboembolism is the main threat. Age is a strong risk factor for AF as well as systemic thromboembolization. Anticoagulation with warfarin is the mainstay of treatment. Rate control with beta blockers and calcium channel blockers is a must. Antiarrhythmic drugs for rhythm control only in selected chronic atrial fibrillation. Cardioversion, catheter ablation, MAGE procedures in only selected patients. So this is, I think, finishes the talk on atrial fibrillation. I hope all of you have understood very thoroughly, and I'm going to share this presentation as well as this video also with you, so you can listen to that. And that article also supplement some of the learning that we had. If you have any doubts, you can ask.